Hello, welcome to lecture 15.1. This week we begin talking about treatment of psychological disorders. So for this lecture, we're going to look at different types of psychotherapy. We'll look at some of the drug categories of psychotropic drugs. We'll look at some of the biological treatments we use to treat certain mental disorders. And we'll look at the differences between various mental health practitioners. Psychological disorders need to be managed over time through treatment in order to alleviate symptoms so people can function in their daily lives until treatment is no longer necessary. Mental illnesses are not cured, they are managed. Now, it is very possible for someone to have an episode of major depressive episode, to receive treatment, and with the skills they learn through therapy, they don't experience another depressive episode. But we don't use the word cure when we talk about mental illnesses because we're not able to stop mental illnesses. We can simply help patients gain tools for their toolbox to better manage symptoms and maybe even prevent episodes from developing. Psychologists and psychiatrists use two basic categories of techniques to treat psychological disorders. They use psychological treatments and biological treatments. So psychotherapy is the generic name given to formal psychological treatments. So these are particular techniques, and the techniques used may depend on the practitioner's training, but all forms of psychotherapy involve interaction between the practitioner and their client. The key to successful therapy is the relationship between a client and their therapist. When we talked about Carl Rogers and Abraham Maslow and humanistic theory, one of the great contributions that they've made is this idea of unconditional positive regard. Since we've already talked about that, I'm not really going to explain it in detail, but this concept is now being used in almost all forms of therapy because the research is conclusive. The relationship between a therapist and their client is critical for successful treatment. Biological therapies are the treatment of psychological disorders based on medical approaches to disease and to illness. So disease being what's wrong with the body, and illness is the symptoms that the patient feels because of the illness itself. So we have many biological therapies for various mental illnesses, and these therapies are based on the notion that psychological disorders result from abnormalities in neurological, so cells in the brain and how the nervous system is working, and bodily processes, the rest of the body. Each of the systems of the body work together, so if the nervous system is off, other systems in the body can be off. And sometimes we'll see psychiatric symptoms with severe high blood pressure. The person may be very anxious. And so we can't just look at the nervous system itself. There are quite a few medications used to treat mental illness, and we'll talk about different meds through this chapter. So psychopharmacology is the use of medication to affect brain and body functions. For many disorders, we're now looking at combining biological therapies with psychological therapy to get the best outcome for patients as soon as possible. And I'll expand on this throughout the lecture. When we have clients engage in psychotherapy, The aim is to change patterns of thought, emotion, or behavior. I always refer to each of us having a toolbox. And as we grow up, we obtain tools and we put them in our toolbox. Some of us receive better quality tools than others. Some of us receive more tools than others. And when we are experiencing difficulties with thought, emotion, or behavior, we can reach into our toolbox and find tools that help us cope. For those who are struggling with mental health issues, sometimes they just need more tools. So their toolbox needs more tools in it, or the tools that they have need to be upgraded. It is estimated there's over 400 approaches to treatment. However, there's a handful of treatments that are most commonly used, and we'll talk about that throughout this chapter. Now, most therapists, when clients go to a therapist for treatment, therapists all have their own ideological approach to treatment based on the training that they have received. Many therapists will specialize in a specific type of therapy, like cognitive behavioral therapy. However, therapists are trained to be eclectic, meaning that they learn multiple types of therapy and can use tools from various therapies to help treat the client to the best of their abilities. So often therapists will primarily use a certain type of therapeutic treatment, but they also have training in other forms of therapy, and that lets them kind of put together the best package for the client, I guess. One of the things we know is that so I've touched on this. One factor known to affect the outcome of therapy is the relationship between the therapist and the client. The quality of relationship is also the best predictor of successful therapy. Most people in the mental health field use the curative power of client expectations to help clients achieve success in therapy. Therapy is collaborative. You just don't go in, and the therapist isn't your teacher who, gives you homework and grades your homework and gives you a grade. They work with the client to see, what does the client want from therapy? Where do they hope to be at the end of treatment? What do they hope to gain through treatment? And how can we get our client where they need to go? So we've talked in chapter 14, we talked a little bit about Freud. Freud and Breuer pioneered the method of psychoanalysis. Again, Freud was not the father of psychology. He's simply the father of talk therapy. And he and Breuer worked very closely together. With psychoanalysis, this is the original talk therapy, treatment involved uncovering unconscious feelings and drives that gave rise to maladaptive thoughts and behaviors. So Freud and Breuer believed that it was the unconscious mind that was acting out when patients would have physiological and psychological difficulties. It was because there were unresolved conflicts in the unconscious mind, and in order to help the patient get better, those conflicts had to be addressed. And two of the most commonly used techniques by Freud is free association and dream analysis. So with free association, I just throw out a word, Christmas tree. And the first thing that comes to your mind is what you would say. So if I'm Freud and I'm doing therapy and I want to use free association, I throw out a word, I record the first thought that my client records. And then I do this with a whole series of words. And the goal with free association is to look for underlying themes, relationships between the words used by the client, by the patient when we're talking about Freud. And the theory is that free association allows the unconscious mind to speak without filter. And dream analysis. Freud did a lot of dream analysis. It's quite fascinating. So the general goal of psychoanalysis. So psychotherapy is this huge category of lots of different therapeutic methodologies. Psychoanalysis is the therapy format that Freud developed. So the general goal of psychoanalysis is to help the client gain insight into their unconscious mind and insight into how these processes affect daily functioning, thus freeing themselves from these unconscious influences. With 21st century eyes, this kind of seems a little odd. Freud left an enormous mark on our society. He found a way to help people before we could help them in any reasonable way. And so, sometimes I see Freud's theory of the unconscious mind as being pretty dark, and that this idea that we are driven by unresolved conflicts to be kind of takes away some of our not individuality, but the concept of independence from our own traumas, I guess, and histories. So when you get down to the nitty-gritty with psychodynamic therapy, I think there's a lot that to 21st century eyes seems unusual. But Freud got people out of institutions. Brilliant man. There are many things that people disagree with Freud about, but we can't overlook his contribution. He made an epic contribution to the Western world, and he changed lives. He helped people get better. So the goal of psychoanalysis was to gain insight, and this is the client's awareness of his or her own unconscious psychological processes and how these processes affect daily functioning. Now, psychodynamic therapy is a related therapy based on Freudian theory. It aims to help clients examine their own needs, their defense mechanisms, and their motives to understand the emotional distress they're experiencing. Now, contemporary therapists do this too. This concept of helping clients understand their own defenses and why they're distressed underlies most therapeutic methodologies. Psychodynamic therapy just worked a lot more with the unconscious mind, and again is just trying to tease apart what is the driving force for the client's mental health issues. And this is Freud's office setup. So you've probably seen some movie or show about Freud and therapy. Freud would have his patients lay down, and he would sit behind them. And he did this so that he didn't interfere, so that his body language, his facial expressions, wouldn't interfere with the patient's ability to reflect and self-report. And I actually think it's a pretty interesting concept. Therapists don't do this anymore. And I think one of the reasons is because we know that the relationship between the patient and the therapist is so critical, and we need face-to-face contact for that. However, that doesn't mean that there aren't therapists out there that might use a couch and sit behind their patient and work with them that way. It's just not it's not a common way to approach treatment with clients now. But Freud wanted to make clients or his patients as comfortable as possible, and he felt like by sitting behind them, he could give them more freedom. And that's very possible. It seemed to really work for Freud. We just, over time, have developed hundreds of other therapies. So psychodynamic therapy has become increasingly controversial. In fact, it's not often used as a sole form of psychotherapy. I have a friend who is a psychodynamic therapist, and she doesn't accept health insurance because health insurance companies don't cover psychodynamic therapy. Because psychodynamic therapy tends to be time-consuming. You go to therapy often. So it's expensive, it's time-consuming, and it's difficult to research the effectiveness of some of the methodologies within psychodynamic therapy. But here's the thing, talking helps. So we now have other therapeutic models with which we get quicker results. They have pretty solid research behind them. But one of the underlying things we see about psychotherapy is that talk therapy in any form helps patients and clients. We just know now that there are other more effective, I don't want to use the word, we have treatments that are less controversial now. Now, my friend who is a psychodynamic therapist, she's well respected, she's well liked by her clients, and psychodynamic therapy is just the approach that makes the most sense to her. But she's upfront with her clients. They come to her if they want psychodynamic therapy. Proponents of psychodynamic therapy argue that short-term psychodynamic therapy can be helpful. Because health insurance companies aren't going to pay for psychodynamic therapy, though, even short-term psychodynamic therapy isn't used very frequently. So, with humanistic therapy, this is when we go back to Maslow and Carl Rogers. The goal of humanistic therapy is to treat the person as a whole, not as a collection of behaviors or repository of repressed thoughts. Humanistic therapy is a huge reaction to psychoanalytic therapy and psychodynamic therapy. With humanistic therapy, this is client-centered. So, rather than digging through and trying to get to the root of unconscious conflict, client-centered therapy is an empathetic approach to therapy that encourages people to fulfill their individual potential for personal growth through greater self-understanding. With humanistic therapy, this can be quite effective. And I'm going to say the majority of other therapeutic methodologies now have embraced some of the underlying theories of humanistic therapy, one being unconditional positive regard for your client. So with humanistic therapy, therapists strive to create a safe and comforting setting for clients to access their true feelings, for the therapist to be empathetic, and they work to accept their client through unconditional positive regard. So just as we've talked about unconditional positive regard, but just as a reminder, this is when your client comes into your office for treatment, you want them to feel cared about. You want them to know that you are invested in their treatment, that you want the very best for them, that you are available to them, that you respect them and like them. Now, this doesn't mean that you allow your clients to walk all over you. You have to set boundaries. But that is part of unconditional positive regard as well. Therapy is a relationship. Now, humanistic therapists use reflective listening, in which the therapist repeats the client's concerns to help the person clarify his or her feelings. This method has also been embraced by most other types of therapy because it's just a really effective way of communicating with other people. Those of you who've taken classes on communication have learned that it can be really helpful to rephrase what someone says so that you can make sure that you're clear about what they're talking about. Motivational interviewing is a methodology used by humanistic therapists, and it can be really helpful for drug and alcohol treatment and for health psychology, trying to help clients become healthier. And that comes back to one of the core parts of humanistic therapy. What are your clients' expectations? What do they want to get? Where do they want to be once they've ended treatment? Then we get to behavioral therapy. With behavioral therapy, treatment is based on the premise that behavior is learned, and thus it can be unlearned. And it really uses classical and operant conditioning. Classical conditioning is reflexive, and it's reflexive on a very physiological sense in manner. Operant conditioning is the more traditional concept of learning of reward and consequences. So behavioral therapists will use both. They look at social skills training, helping the client to identify appropriate ways to act in specific situations, and helping them learn how to engage in those behaviors so that they're behaving in a manner that meets the social situation. One of the things behavioral psychologists will do is modeling, trying to demonstrate how the therapist actually uses their social skills training. One of the treatments, so behavioral therapy is pretty effective for phobias. When we talk about cognitive behavioral therapy combined, I'll go into more detail. But one of the things we see is that behavioral therapy can be very helpful for the treatment of phobias, because phobias are irrational. And so thinking about your phobia just increases your anxiety. So one of the things behavioral and cognitive behavioral therapists will do is, so I'm afraid of spiders. Found one in the bathroom the other night, didn't have my glasses on, so I didn't notice it first. All of a sudden there's this big black thing coming at me. Did the little spider dance, did my little shriek, got a deep breath and killed the sucker. We have phobias. We don't generally get treatment for phobias unless that phobia is interfering with our daily functioning. I don't work out in the woods where I'm going to encounter a lot of spiders. So I don't go to therapy for my spider phobia because it just doesn't impact my life very often. And when it does, it's pretty minor. It's, doing the, oh my God, it's a spider dance and a little shriek. Not a big deal. We use exposure therapy with clients for whom their phobia is interfering with their daily living, and it's causing them subjective distress. So exposure therapy is a technique that involves repeated exposure to an anxiety-producing stimulus or situation. This is a very effective treatment for obsessive-compulsive disorder. We also use exposure therapy to help treat post-traumatic stress disorder. Now, that's a complicated way. Treating PTSD is very complicated, and I am not well versed enough in the exposure therapy for PTSD to really be able to expand on it much. And I'm hesitant to go further on that simply because PTSD is so complicated that I think, that the treatment of PTSD and these therapy for PTSD could be an entire class on its own. But we do know that exposure therapy can be helpful for those with PTSD. So, it's very effective for obsessive compulsive disorder as well. Now, systematic desensitization is a method in which the therapist exposes the client to increasingly anxiety-producing situations by having their client imagine them and then teaching him or her to relax at the same time. I just need to check my next slide. Okay. So, first, there's this great show called Raising Hope. It's been off the air for a while now. I watch it all the time, though. There's, on Moodle, in the folder titled Chapter 15 Treatment Lecture Videos, you'll see the clip Spider Scene from Raising Hope. So please watch that now. Welcome back. So that is how you do not do exposure therapy. Now, Jimmy isn't known as the brightest bulb in the box, so he thought he was doing a great thing. He was not. He is going to make Sabrina's phobia so much worse, because that is not how you do exposure therapy. So in your textbook, you have a figure like this, and it's a really basic introduction to the concept of exposure therapy. So, let's say your child has a phobia of dogs. One of the things that a parent can do is just gradually expose their child to dogs that they already know are safe and friendly. And you just, over time, that child can get over their fear of dogs if they have enough positive interactions with dogs. So, when I was in graduate school, one of my colleagues was working with spider phobics, arachnophobics. And she worked with a tarantula. Now, I never went into her office because, tarantula. But the way she would work with clients is that at first, you meet with your client and you don't even have the tarantula in the room. You get to know each other, you get an idea of what the patient's goals are, where they want to be at the end of treatment. And then in at the next therapy session, the tarantula will be in its aquarium. It will be at the opposite side of the office from the client. Now, if someone has arachnophobia severely enough to go to therapy for it, that's going to create some anxiety. Just seeing the tarantula and knowing that it's in the room is enough to cause some pretty intense anxiety. Over time, at each visit, the aquarium will be slightly closer to the client. You're just getting them used to seeing the spider and to seeing that the spider and understanding that the spider is in an enclosed tank, that they're not at risk, that the tarantula isn't going to be able to startle them, and you help them learn coping mechanisms when they're feeling very anxious, like deep breathing, guided imagery, positive self-talk, and gradually the client's able to sit next to the aquarium. Has the spider heebie-jeebies, doesn't like it, but is able to do it because they've learned how to slow their body down. Instead of panicking, they're learning how to control that anxious response. And with time, you might get to the point where the client can even put the tarantula on their hand. I'm not going to do that because I don't have to work around spiders. I used to live in southern Arizona, where we had things like this. We had wolf spiders, big-ass spiders, and they carry their babies on top of them. So you can't step on them, because if you step on them and they have babies on them, all of a sudden you have hundreds of those spider babies everywhere. I left Arizona as soon as I could. Spiders were just part of the issue. No, that's not really why I left Arizona, but I didn't like living someplace where spiders carried their babies on their back and those babies could spray everywhere. No, I'm not going to do it. Then we come to cognitive therapy, and this is treatment based on the idea that distorted thoughts produce maladaptive behaviors and emotions. And with treatment, you try to modify these thought patterns. Now, the efficacy rate for behavioral therapy and for cognitive therapy are very high. Cognitive behavioral therapy, the combination of cognitive and behavioral therapeutic methodologies, when these two are combined, this has become kind of the gold standard for most psychiatric disorders. So with cognitive therapy, if you're just doing cognitive therapy on its own, you're going to do cognitive restructuring, and this could include rational emotive therapy as well. So cognitive restructuring. This is a therapy that strives to help clients recognize maladaptive thought patterns and replace them with ways of viewing the world that are more in tune with reality. So I, in a previous lecture, shared that when I hit puberty, I developed OCD and became an obsessive hand washer. If I would touch something, I'd have to then go wash my hands. It didn't matter how clean the thing is that I touched. I just could not stop stressing about germs. And my mom didn't quite get it. My parents could just see it, but they didn't know why. They just thought I was washing my hands too much. But, I got a grip on it. It wasn't bad. But once COVID-19 took over the world, for the first time in my life, I felt those obsessions and that compulsion to wash my hands kick in. Now, as most psychologists, I have done therapy. And I have done a lot of cognitive behavioral therapy when I did therapy. So I learned how to restructure my thoughts. I haven't become at the mercy of hand washing again because I'm able to restructure my thoughts about germs. So I remind myself, okay, I washed my hands for a good 20 seconds. That's what I'm supposed to do. My hands are clean. It's okay to finish. It's okay to just walk away. And maybe I start feeling anxious again. I just remind myself, you know how to behave with this virus. You've been taking all of the precautions. You've engaged in good hand hygiene. You're doing everything you can. It's okay. I'm having to tell myself it's okay all the time. And I got back on top of the obsessive thinking about germs, but also the hand washing. I still get a little stressed when I come home from the grocery store. I do feel like, oh my God, I'm so contaminated. I'm not. And I know that. So I just do the hand hygiene and remind myself that's what I needed to do. That I followed all the rules. I wear a mask, so should you. And because I've had the chance to learn how to restructure my thoughts, I'm not at the mercy of that anxiety anymore. Another thing I can do is sometimes if I'm getting really overwhelmed by thinking about germs too much, I distract myself with something else so that I'm forcing my mind to focus on something else. That's a skill that I learned, and I learned that through therapy. There's also what's called rational emotive therapy. In this approach, the therapist acts as a teacher. explaining the client's errors in thinking and demonstrating more adaptive ways to think and behave. For those of you who had me in 201, you know that I lecture a lot on sleep because we are a culture that actually celebrates sleep deprivation. And I try to live what I say about how to sleep well, what you should do to get better sleep. But I don't lie to my students about, okay, I follow all of these to the letter, because I don't. I try. But I do think I do a good job of explaining to students, here's why you need to sleep. Here's why you need to make sleep a priority. And here are things that you need to be aware of so that you sleep well and you have healthy sleep. And in rational emotive therapy, you are taking on that teacher hat. You are demonstrating adaptive behaviors and thoughts. That brings us to interpersonal therapy. And this focuses on circumstances, namely relationships, that the client attempts to avoid. So there are two forms: mindfulness-based cognitive therapy and cognitive behavioral therapy. So mindfulness-based cognitive therapy maintains that people who recover from depression continue to be vulnerable to faulty thinking when they experience negative moods. There is lots of research to support this, and it's one of the reasons why therapy is so important for those who experience depressive episodes. It's easy to fall back into the pattern of maladaptive thinking when you have a bad day. And so one of the things that we do with clients is we help them identify when they're falling back into maladaptive thought processes. Just helping them identify that they're experiencing maladaptive thoughts can be enough to remind them to reach into their toolbox and use the tools that they have so that they don't fall back into patterns of frequent maladaptive thoughts that influence then their behavior. With cognitive behavioral therapy, this is a therapy that incorporates techniques from cognitive therapy and from behavioral therapy to correct faulty thinking and change maladaptive behaviors. Let me just check my next slide. Okay, so here we've got an example of maladaptive thinking. My boss yelled at me. I'm worthless. Thoughts like that lead us to become depressed. Once you've learned how to assess your own thoughts for accuracy, I think is perhaps the best way I can say it. You learn how to think adaptively in a way that helps you survive and reproduce. My boss yelled at me. I guess my boss is having a bad day. You're not taking responsibility for things that aren't your fault. So if, let's say I'm a therapist, I'm not. I have no therapy training. I took one class on it. But I'm going to pretend to be a therapist. And I have a client come in who's experiencing a lot of depression. Often, the most effective treatment is a mixture of cognitive and behavioral therapy. So, for behavioral treatment, when we're depressed, we don't want to go to work or school, so we miss work and school. We don't shower as often. We don't eat a healthy diet. We either eat too much or too little. We don't exercise. Our social interactions become more limited and less frequent. And so for the behavior aspect of cognitive behavioral therapy, I'm going to challenge my client to shower every morning. Doesn't matter if the client wants to or not. They just have to do it. They're going to get up at the same time every morning and get out of bed. They're not going to just lay there awake. They're going to get out of bed and start their day. they're going to eat a healthy breakfast. And over time, I'll challenge them to have their other meals be really healthy too. But we've got to start in small steps. So I'm going to challenge them to change their behavior, because there's lots of research that shows if you change your behavior, you change your mood. If you stop behaving in a depressed manner, your depression can lift. But adding cognitive therapy to that is extremely effective. The mix of cognitive behavioral therapies is generally, for most clients, the fastest therapeutic method to use for them to get relief from their symptoms. So with cognitive therapy, I'm going to have them start writing down some of their thoughts. And then I'm going to ask them, okay, let's look at this one thought. You said that you were a bad person because you missed a lecture. How accurate is that? Are you a bad person for missing one class? Of course you're not a bad person for missing a class. But when someone's depressed, they feel like they're bad people when they don't meet an obligation or an expectation. And so you just help them learn how to restructure those thoughts. Because maybe they just needed a mental health day. So, the challenge behaviorally is to go to all your classes. With cognitive restructuring, though, it's helping the client to not judge themselves for not meeting an expectation. And it's a delicate balance of when do I just allow myself to feel bad? And when do I just force myself to do stuff? With time, the balance becomes easier to maintain, and that helps clients come out of a depressive episode. Now, group therapy rose in popularity after World War II. In your forum this week, we were talking about collective trauma. World War II created tremendous collective trauma in the United States. And so all of a sudden, we had a lot of people that needed therapy. And we did not have enough therapists to treat them. So group therapy was developed and still used today quite frequently. I just need to check my... Okay. So one of the advantages of group therapy is it's a lot less expensive. And the group setting gives clients the opportunity to improve their social skills and to learn from other people's experiences. Group therapy allows clients to practice social interaction in a safe space and with people who are sharing the struggles that individual is sharing. So you get the feeling that you are not alone in this world. You're not the only one that is struggling to get out of bed every morning and go to work. You're not the only one who's gained 10 pounds because you're so depressed you're eating a lot more. You're eating your feelings. You find a group of people with whom you can be honest and open, and you're not judged. And then you go back to your regular life. And then you go back to your group therapy the next week. And it's a way for you to express what you need to express, practice things you need to practice, but to do all of those things in a safe, regulated way. Then we get to family therapy. So according to the family systems approach, an individual is part of a larger context in which changes in individual behavior will affect the whole system. Some therapists insist that family members be involved in therapy. And for a family therapist, the family is the client. Now, people aren't going to go to family therapy unless the family is willing to be the client. Something that we see is that in families, when things go badly, when the family has become very stressed, often one person is identified as the problem. Now, if you have someone in the family that's experiencing depression or anxiety, struggling with mental health issues, all of a sudden, they are the person who gets blamed for everything that goes wrong in the family. But let's be honest, no one person is at fault for everything going wrong with the family. So families tend to choose a target person on whom to blame for what's going wrong with the family. This is where family therapy can be extremely helpful, because it helps the whole family learn to work as a whole again. Rather than having the target troublemaker, the family learns, okay, here's the responsibility of each person. How do we help each other? How do we become less judgmental with each other? How do we become more patient with each other? But how can we tell each other the truth and still demonstrate compassion, caring, and love? So, let's say you have a child, a couple has a child that has really severe ADHD, and say their child's 7. And it's causing a lot of stress within the family unit, especially because the child isn't responding to medications. With family therapy, you don't just work with the child's behavior. You also help the parents learn how to parent a child with severe ADHD. Because a child with severe ADHD is not like other children. They have a neurological disease. ADHD is a neurological disorder. And so you will work with the child and their behavior too, but you'll help the family learn how to communicate more effectively, and you'll help them come up with strategies to resolve conflict before that conflict has snowballed and become out of control. With family therapy, you have what's called expressed emotion. This is a pattern of negative actions by a client's family members. The pattern includes critical comments, hostility directed towards the person by family members, and emotional over-involvement. So y'all just read that and you thought, oh fuck, that's my family. All families engage in these. We all have times where we just snap and we make critical comments, or we think we think we sound like we're joking when actually we just said something extremely hostile, and I'm now telling the person, well, it was just a joke, so what are you so upset for? Sometimes we become emotionally over-involved with people in our family. The issue is, are these occasional moments, or are these a family pattern? And this has become a family pattern. The family needs help. So, with expressed emotion, the level of expressed emotion from family members actually corresponds to the relapse rate for those with schizophrenia. So how families emote, how they express emotion, has tremendous impact on how a family member with mental illness, how well they do. This does not put responsibility on individual family members for the mental health of the person struggling. But what this does is it helps the family learn how to work together to help the family member who's struggling and to develop healthy communication patterns. I'll let you read about relapse rates. So now let's talk about psychotropic medications. These are medications that affect mental processes. So we're going to talk about several different types of psychotropic medications, and in future lectures we'll look at this in a little more detail. So one of the categories are benzodiazepines and tranquilizers. So this is a category used to treat anxiety disorders. Benzodiazepines are very much used for anxiety. Now, this drug category can also be used for insomnia, but we've been limiting the use of benzodiazepines a lot in the last couple of years because they can be highly addictive. Now, just because a drug is highly addictive does not mean it shouldn't be used. It just means we have to be attentive as we prescribe these drugs to patients. That we need to educate our patients about these drugs, and we have to be very careful in how these drugs are distributed. Anti-anxiety drugs, so benzodiazepines actually increase what's called GABA. It's a neurotransmitter, and GABA helps us feel more relaxed. It slows the brain down, and when we are overly anxious, the brain is going too fast. You need to slow it down. And those of you who've ever had a panic attack, you know the feeling of you cannot slow your body down. It's not just your brain. It feels like your whole body is revving up and you can't stop it. And so by increasing GABA activity, you slow the brain down, and that decreases anxiety. Antidepressants. I know you probably know quite a bit about antidepressants. There are many categories of antidepressants. So this is a class of psychotropic medications used to treat depression. And in the next two lectures, we'll look at different medications in more detail for different disorders. So with antidepressants, these are often prescribed for those with anxiety disorders because one of the symptoms of depression can be anxiety. So if you have a patient who is really depressed and they're having a lot of anxiety with their depression, you might go with a drug like a selective serotonin reuptake inhibitor, an SSRI. A couple names would be Prozac, Paxil. There's a bunch of them. And that will help both the depression and the anxiety. Sometimes we'll prescribe SSRIs to those who have anxiety without depression because serotonin dysfunction is related to depression, but also anxiety. We will use SSRIs sometimes to treat post-traumatic stress disorder. Definitely use them to treat depression. I know that some doctors will prescribe SSRIs to treat, to help men who ejaculate too quickly, because one of the side effects of SSRIs is decreased sexual sensitivity, and so it can actually help with men who have premature ejaculations. There are monoamine oxidase inhibitors. These are not a commonly used category of antidepressants anymore because SSRIs came along and they just have fewer side effects. Tricyclic antidepressants, very, very, very rarely used for depression anymore. They were one of the first categories of antidepressants and very effective, but they're extremely sedating. So now we are more likely to use these to treat insomnia than we are to treat depression. So when we look at psychotropic drugs, one of the things we see, I know many of you haven't taken Psych 201, so I'm not going to test you on how does this work. Those of you who took 201 know how SSRIs work on a cellular level. But with SSRIs, we can actually change how neurons fire, how they send messages and receive messages. We can regulate the level of serotonin in the brain, because one of the things with depression is that often there's an imbalance with serotonin. And so SSRIs allow us to restore better serotonin functioning. Antipsychotics are a class of psychotropic medication used for the treatment of schizophrenia and other disorders that involve psychosis. They can also be used as for the treatment of epilepsy. Sorry, scratch that. Antipsychotics are not used to treat epilepsy. These are also known as neuroleptics. So antipsychotics, it's a really brilliant category of drugs. These drugs first came out, I want to say the 40s or the 50s. They're pretty intense medications. These aren't widely distributed. But for those with schizophrenia or diseases similar to schizophrenia, antipsychotics save lives. Not just like actually saving the physical life of a person, but helping them get their life back. For most of human history, those with schizophrenia were institutionalized. The only issue is what kind of institution were they placed in. And antipsychotics gave doctors a treatment method that allowed some patients to leave institutions. It got their symptoms controlled enough that they could go home. Now, for those who had schizophrenia so severe that they needed institutionalization, this doesn't mean that antipsychotics gave them their life back to the point where, they were able to go to work and have families and live life like those without schizophrenia. But what it did is it did let them get back into normal society. They were still ill. Schizophrenia is a brutal illness. But they didn't have to be in institutions anymore. Now, one side effect of antipsychotics is what's called tardive dyskinesia. And this is involuntary twitching of the muscles, especially in the neck and the face. Now, this is a potential side effect with SSRIs as well. Very unusual for this to occur when someone's taking an SSRI. Tardive dyskinesia is a possible side effect with antipsychotics. We now have a category of antipsychotics called atypical antipsychotics, which are much less likely to cause tardive dyskinesia. Antipsychotics have a lot of side effects. So does schizophrenia. And so this is where we have to find, okay, what antipsychotic can we try with this patient? How does it affect their symptoms? And do they have a better life on that medication than off of it? So something that antipsychotics will do is cause a lot of weight gain. So you work with your patient to help them understand they need to eat a healthy diet and they need to weigh themselves regularly. And you help them learn how to monitor their weight. It's the cost-benefit question. These are pretty intense drugs. Thankfully, we have the atypical antipsychotics now, which are much easier for people to handle. But for some with schizophrenia and similar disorders, they still need the old-fashioned heavy antipsychotics. And schizophrenia is just so intensely difficult to treat that you just have to go with what you can use, with what works. Then we get to mood stabilizers. Mood stabilizers are typically used with bipolar disorder. And we talked about how, there's bipolar 1 and bipolar 2. Well, lithium is considered the gold standard treatment for bipolar disorder. It's not, we have additional mood stabilizers now, so, it's not like we're handing lithium to everybody who has bipolar disorder. Lithium tends to work best for those who have manias with their disorder. But it's really amazing. This simple salt helps people stabilize. For those who can't take lithium, it's often because of nausea or weight gain. We also use anticonvulsants, anti-epileptic drugs to treat bipolar disorder. It's really quite amazing that anti-epileptics can treat bipolar disorder very well. The dosage is different, and how you medicate bipolar disorder is very individual. So lamotrigine will work very well. It's an anti-epileptic, works very well for those with bipolar 2. Not so great for those with bipolar 1. Lithium works really well for bipolar 1. And so you just have to look at the individual patient, their medical history, what their symptoms are like. Are they bipolar 1 or 2? And make treatment decisions, medication decisions from there. It's not unusual for those with bipolar disorder to be on what's called a drug cocktail, where they're using multiple psychotropic drugs to get their symptoms under control. Same thing goes for schizophrenia. And as we talked about last chapter, these are the two most difficult mental illnesses to treat. There are patients who are treatment resistant. They don't have successful therapy, medication, combining the both, they just aren't responding to either form of treatment, talk therapy or medication therapy. And so sometimes we'll use alternative treatments for patients. Because there's so many medications now, we don't typically need to use these alternative treatments, but we do use them. If you have someone that is just not responding to anything, turning to alternative treatments makes a lot of sense. So there's something called trepanning, and I think I talked about this in chapter 14, that most cultures for a very long time believed that mental illness was a spiritual illness, that you had to get rid of the demons, that it was evil spirits or demons had actually possessed the person, giving them symptoms of mental illness. And so we have found skulls that have been trepanned. And trepanning is a form of surgery. So the skull is tens of thousands of years old. And we can see here that there were at least 2 surgeries, maybe 3. Cultures that used trepanning, the goal was to release the evil spirits from the person's skull so that the person could become well. And people survived these surgeries. They're not safe, of course not. But we are finding skulls where trepanning happened, and you see that these areas have healed. All 3 of these areas show evidence of healing. And then there's also psychosurgery, the prefrontal lobotomy. And there's a great documentary called The Lobotomist. I really recommend watching it. And it's about Walter Freeman, who brought the prefrontal lobotomy to America. And it's pretty brutal. It's not something we do anymore. Basically, you insert a metal probe under the top eyelid into the brain, and you just swish. You just kind of wiggle it around, and it just severs all kinds of connections in the frontal lobe. The prefrontal cortex. And I really recommend the documentary. One of the great, brilliant things about antipsychotic drugs is they helped eliminate the use of lobotomy. There's a good book called My Lobotomy, in which a man was treated by Walter Freeman. His stepmother hated him. And when he was 12, she took him to see Walter Freeman. He was just a difficult kid. He wasn't mentally ill, though. He was just difficult. Freeman gave him a prefrontal lobotomy. Complete abuse. I don't know why Freeman thought that was appropriate, but Freeman got a little weird towards the end there. Okay, if you want to talk more about lobotomy, just contact me. Or watch the documentary, it's super duper good. And that brings us to an electroconvulsive therapy, ECT. ECT is a procedure that involves administering a strong electrical current to the patient's brain to produce a seizure. ECT is extremely effective for the treatment of severe depression, of treatment-resistant depression, and bipolar disorder. So this was first developed in the 1930s, first used on a human in 1938, and this became a very common treatment for schizophrenia, severe depression, bipolar disorder, about the 1950s and 60s. But once we developed medications to treat these disorders, ECT became less prevalent. But it's still very helpful. So if you have someone that's treatment resistant, they've done therapy, they've done multiple medications, and they just cannot come out of their depressive episodes, ECT is actually a very effective treatment. The general public has a very negative view of ECT, and I think one of the reasons for this is the movie One Flew Over the Cuckoo's Nest. So, I'd like you to take a quick break and watch the ECT scene from One Flew Over the Cuckoo's Nest. You'll find that in the Chapter 15 treatment lecture videos. The movie One Flew Over the Cuckoo's Nest is brilliant, and that is not how ECT is done anymore. Now, electroconvulsive therapy uses anesthesia, and so the patient is given powerful muscle relaxants in an anesthesia, so that what ECT does is it triggers a seizure in the brain, and as you saw in One Flew Over the Cuckoo's Nest, the whole body just becomes rigid and it starts convulsing, and it's quite violent. We don't do ECT like that anymore. Now patients are given very powerful muscle relaxants. They're under anesthesia, and you put a blood pressure cuff and inflate it either around a foot or a wrist. What that does is it blocks the medication from getting to that part of the body so that you can see when the seizure is actually happening. But the rest of the body stays limp. So they're not body isn't experiencing the trauma of that kind of seizure. ECT is the most effective treatment for severe depression that there is. It's just not the first thing we go to, though. The one exception I can think of for that is in elderly populations that can't tolerate psychotropic drugs. But that's rare. And even then, you're going to start off with trying antidepressant drugs first before you turn to ECT. But when you have patients who simply cannot function and are not responsive to any other form of treatment, ECT, it looks brutal, but it's not. It is extraordinarily effective. So please watch the 3 videos. 1, ECT, electroconvulsive therapy, Ride the Tiger, the benefits of electroconvulsive therapy. And there's a video, TED Talk with Sherwin Newland, who's a surgeon, and he talks about how electroshock changed him. So please look at those. I did a large report in graduate school on ECT about, does ECT cause brain damage? And the answer is no. Patients do have some memory issues when they're receiving ECT. So basically it interferes with memory encoding of information that's occurring at that specific time. But they don't forget their past. They're just not going to remember what they had for breakfast the day of their treatment. And their memory might get a little fuzzy for the 2 or 3 weeks for the events that happened during the 2 or 3 weeks of treatment that they had. But ECT does not cause brain damage. That's a myth. Now, every procedure has its risks. You cannot say that ECT does not come with some risks. It does have risks. But so do medications. Again, it's the cost-benefit ratio. Then we come to transcranial magnetic stimulation. This is fascinating. It's rather new. We just had a TMS clinic open here in Eugene, which I'm so excited about. So transcranial magnetic stimulation uses a powerful magnet. And what happens, so right here we've got the TMS magnet, we've got the treatment coil here, and you put it over the patient's skull. And I don't know how they pick which areas to stimulate because I'm not a physician, but by rapidly turning the magnet on and off, this induces an electrical current in the brain, and it interferes with the neurological functioning in that brain region, but not on it's interrupted just during the session itself. And so, for some reason, this helps people with treatment-resistant depression. And I'm excited that we have a clinic here in Eugene now, because I think this is a really important treatment option, especially for those who can't use medications for X, Y, and Z reasons. And ECT also interferes with brain functioning. For some reason, it's like rebooting your computer. These two methods, very different in how they work, but by interrupting this neurological functioning, it's like you're rebooting your computer. And sometimes the computer starts acting up, you just reboot it and everything's fine. Okay. So please watch the video titled Transcranial Magnetic Stimulation for Depression in the Chapter 15 Treatment Lecture video file. And then we get to deep brain stimulation. And with deep brain stimulation, this is brain surgery. Not something that we do very often. Electricals are surgically implanted deep within the brain, in the limbic system. And let me just show you the next slide. The pulse generator is connected to these implants in the limbic system, and the pulse generator creates small electrical interruptions into the part of the brain that they're implanted in. Very, very mild electrical energy. And treatment, so when you're using this, the pulse generator can be set at different intensities and different frequencies. So you'll adjust the pulse generator until you get the results that you're hoping to get for that patient. DBS is being used a lot with Parkinson's disease. Parkinson's is a devastating disease. I worked with a man who had advanced Parkinson's. He had tried deep brain stimulation 3 times. For him, it just didn't work. For others, it works very well. DBS is also being used to treat severe depression and severe OCD. This is actually an extremely helpful treatment for obsessive compulsive disorder. But we're talking about extreme cases. So I have episodes where I get a little preoccupied with hand washing, but I have a grip on it. I'm able to use cognitive behavioral therapy skills, and I'm fine. This is only going to be used with cases in which the patient has OCD to the degree that they can't live a life. They're completely paralyzed by their disease. Okay, we're almost done here. So now I want to look at the types of providers who treat mental illnesses and psychological disorders. There are many people, specialists who can treat mental illnesses, but their role in treatment is specific. So, we have clinical psychologists. Clinical psychologists have a PhD or a PsyD in clinical psychology. They are specifically trained to work as therapists for patients with mental illnesses. They don't prescribe prescriptions. They only do therapy. Psychiatrists are medical doctors. They can prescribe psychotropic drugs. Now, they do receive some training in therapy, but they aren't typically providing therapy. They will work with therapists so that both the psychiatrist who's prescribing medications and the therapist who's doing therapy, so that they can monitor the patient's progress, see if the medications are working or not, is the medication helping with therapy. So they're working together to get the best outcome for the patient. Counseling psychologists have a PhD. Sometimes they have a master's degree. It depends. They look more at adjustment problems rather than mental illnesses. So a clinical psychologist works with mental illness. A counseling psychologist looks more at adjustment problems. So people are just having a difficult time, but they don't have a mental illness. Psychiatric social workers have a master's degree in social work, and they work in a variety of settings. They will work with psychiatrically ill patients and families. They do therapy on an outpatient basis, but sometimes they're working with inpatient patients, helping to facilitate therapy in psychiatric units. You have psychiatric nurses. They have a bachelor's degree and usually a master's in nursing. They work in all kinds of facilities, and they have private practices, and they can prescribe medications. Now, they always work under a MD's supervision, so they always have an MD to go to, and they will refer someone out to a psychiatrist if that nurse practitioner feels like, okay, this patient is really getting so ill that it's beyond my skill range. They'll refer them to a psychiatrist, often the psychiatrist that that the nurse practitioner is already working with. You have paraprofessionals. They have a little advanced training. They work with the mentally ill, but they're not providing treatment. So I've been thinking about doing the training for Cahoots. And Cahoots helps people who are having psychiatric crises within the community. You've seen the white van that says Cahoots on it, and they help, they respond to situations where someone's having a psychiatric crisis. That's a paraprofessional. They do have some training, but they're not going to provide treatment. Another example would be someone who works in a group home for those with mental illnesses. They have some training. They don't treat the person with mental illness. They assist the person who has a mental illness. And then we have technology-based treatments. Right now, for those that are doing therapy or also just seeing your doctor, a lot of us are doing televisits. and that's a technology-based treatment. It's not something psychologists like doing. They prefer to see face-to-face, and I think clients prefer to meet face-to-face, but these are extraordinary times. So, let me check my next slide. So we've got, this figure is in your textbook, so it'll be helpful for you as you learn the difference between each of these types of specialists. There are 2 states in which clinical psychologists can obtain additional training so that they can then prescribe medications. And these states are the population is very rural, and there just aren't enough psychiatrists in those states. And so clinical psychologists, they have to have a PhD or a PsyD. They can obtain additional hundreds and hundreds of hours of training that allow them to prescribe basic medications. And of course, they're working under a doctor who's supervising their what they're prescribing, whom they're prescribing. But there is a shortage of psychiatrists right now, especially child psychiatrists. And so I do think that allowing clinical psychologists who are interested in prescribing, providing them with a structured training and then professional supervision whenever they prescribe is a great solution to the shortage of psychiatrists. It's so difficult to find a child psychiatrist, especially. I know this was kind of a long lecture, so I hope you're doing well with your reading and your assignments. I am available. Please don't hesitate to contact me. Thank you.